Hi, I'm Niamh Healy. I'm a long-term member of Cuidiú and I'm now honoured to be Cuidiú's president. I've been a Cuidiú Antenatal Ireland teacher since 2005 and a tutor on our antenatal teacher training programme since 2013. I have worked on 3 editions of Cuidiú's Consumer Guide to the Maternity Services in Ireland. I also teach baby massage.
Hi, I'm Mim and Mim. I'm also a long-term member of Cuidiú. I've been a Cuidiú antenatal teacher since 2004, and I'm also one of the tutors on the antenatal teacher training programme since 2013. I was a Cuidiú breastfeeding counsellor for 7 years, and I've been a birth doula since 2005.
We are both fully qualified birth trauma resolution therapists, and we'd like to help you understand more about birth trauma, its potential impact on the breastfeeding dyad, and what you can do to help.
We hear from lactation consultants that mothers often open up to them about how they feel about their birth experience during the breastfeeding consultation. Often, breastfeeding gives some mothers a degree of control if they felt they had none during the birth experience, and so are very motivated to make it work.
We hope this short video will help IBCLCs understand what birth trauma is and where it may come into your workload, and when to guide mothers to the specialist support they need to deal with this issue.
Let's have a look at how the brain processes memories. When we experience events, the brain uses the amygdala to give it emotional context before storing it in the hippocampus. For example, a pleasant restaurant dinner, where the amygdala contextualizes it with the food, the staff, the ambience, and then stores it long-term in the hippocampus as a past tense story. The brain likes to pattern match and can do so with specific details from our memories. That's why we can be brought right back to a childhood memory through a smell or even a song. However, when we experience a traumatic event, the brain is flooded with adrenaline. This stops the amygdala from contextualizing, adding context, and causes it to be stuck in the amygdala with the visceral, fearful responses and emotions still attached. When the brain pattern matches and becomes triggered by a sensory reminder of the traumatic event, like seeing or smelling something, the person experiences symptoms like panic attacks or flashbacks, and the same intense, present tense emotions from the event. Sometimes these triggers are obvious, like hearing a birth story, but sometimes symptoms can seem to come out of the blue. For example, being triggered by a specific word or a color. They may not have consciously associated this with their birth experience. This can be very confusing and unsettling. 80% of people can process their trauma themselves naturally within 4 to 6 weeks. However, the remaining 20% still find themselves being triggered, living in present tense reactions to any brain pattern their brain matches to. As lactation consultants, it's important to be aware that in some cases, their baby or their partner can be the trigger, so the trauma symptoms are relentless. This can manifest as not wanting their baby out of their arms to a point of excluding their partner. And whilst this is possibly promoting responsive breastfeeding, the stress levels involved are not good for her mental health. Or it can manifest as a disconnect from their baby, which could negatively affect breastfeeding.
Wouldn't it be nice if birth was a lovely positive event for everyone? But we know that's not the case for a lot of parents. During pregnancy, most parents think that a healthy baby is the most important thing. And it is, but it's not the only important thing. It's important that parents are left emotionally and psychologically well after birth, not just physically or clinically well. Some people are disappointed or upset by their experience, and we know that listening and validating can be very helpful for these people. However, others find that their experience leaves them with temporary or long-lasting symptoms of trauma. Some will even have PTSD. Up to 30% of parents describe their birth as traumatic, according to recent research in Europe, Australia, the US and elsewhere. Estimates for full-blown PTSD after childbirth vary from 3 to 8%. Birth trauma affects mothers or birthing people, but it can also affect fathers or life partners or birth partners too. There are some very obvious causes of birth trauma. Rare, life-threatening events for mother or baby could cause PTSD. Things like emergency hysterectomy, baby born unresponsive or seriously ill, shoulder dystocia, severe hemorrhage, perhaps extremely fast births. The fact that some other serious events in labour are more common doesn't make them less traumatising to parents, such as emergency caesarean, forceps, epidural not working, fetal heart concerns, baby needing some resuscitation, baby spending time in NICU, etc. And parents often engage the help of an IBCLC if their baby has had a difficult start, to inform and support their breastfeeding journey. These are situations that most people can understand would be very upsetting. What's less obvious is that how a mother was treated at any time during her care can have a lasting impact on her. Examples could be staff being unkind, or dismissing or disrespecting her, or disregarding what she is saying, or not involving her in decisions, or not getting true consent for procedures. Offhand words or certain tones of voice can have a far greater impact than most healthcare professionals realise. Ultimately, it's about how they felt. Were they scared? Did they fear for their life or their baby's life? Did they feel that they had no control over what was happening to them? Did they feel that they had no voice or that nobody was listening to them? Did they feel trapped in the situation? Did they feel lonely and unsupported for a long time? Was there an extreme gulf between their birth or breastfeeding expectations and reality? Parents may not think their feelings around how they were treated and how they felt are valid if the outcome was okay, but their feelings are just as valid as after the more dramatic clinical situations. So let's have a look at a couple of stories. We have Mary and Joan. Mary had a straightforward enough time going into spontaneous labour and birthing her baby vaginally. Joan, however, had her labour induced, was pushing for a long time, had 2 failed attempts at forceps and ended up with an unplanned caesarean. So it might look obvious that Mary is less likely to be traumatised than Joan, but let's have a closer look. Mary spent a lot of her labour alone and frightened. She didn't get the epidural she wanted. She felt staff didn't listen to her. She and her baby were too shocked by the fast birth to enjoy skin to skin in the golden hour. She tells her IBCLC that she doesn't know why she feels so unhappy about her birth. She knows it was quite straightforward, but she is determined to breastfeed. Joan negotiated her care every step of the way. She went home after the first step of the induction process. She felt fully involved in the decision-making at all times. She felt respected and listened to at all times. She got skin to skin and her baby latched on in theatre. She felt positive about her birth, even though it wasn't what she had hoped for. So you see, the clinical summary of how labour and birth went well doesn't tell us the whole story. People, family and friends around new parents make all sorts of assumptions, and we know society sends parents clear messages about just getting on with it regardless of the birth journey they've had. And IBCLCs are in a privileged position to provide sensitive support in these cases. This societal expectation of parents to embrace parenthood no matter how their birth experience was is completely unreasonable. A good outcome being a live mother and a live baby is a pretty low bar to set. There's a good analogy for that. There's a person who wanted to go to Disney World for years, really wanted to go there with their family. They saved up and booked a trip, couldn't wait, arrived at the airport so excited, got on the plane, enjoying the movies. Then they were hijacked and held at gunpoint for several hours, not knowing if they were going to live or die. Thankfully, they were rescued by a SWAT team and they were able to resume their journey to Florida. How likely were they to enjoy the Disney parks on their holiday? Should we expect them to have positive memories? How understanding would family, friends, society be about their inability to embrace their dream holiday after what had happened to them? And contrast this with how society expects new parents to act or feel in the early weeks and months of parenthood.
Diagnosing PTSD and postnatal depression isn't clear-cut, unfortunately. The current method to diagnose PND is the Edinburgh scale, which lists symptoms of PND such as sadness, anxiety and worry, and difficulty looking forward to things. Many healthcare professionals do not have access to or knowledge of PTSD diagnostic tools, which look for key PTSD symptoms such as flashbacks, panic attacks, hypervigilance, avoidance behaviours, etc. You're probably familiar with the symptoms of postnatal depression. For example, feeling unable to laugh or see the funny side of things, not looking forward to things. PTSD symptoms include intrusive thoughts or memories, nightmares, flashbacks, avoidance, hypervigilance. Parents have told us the lengths they go to avoid passing the hospital where they gave birth, or needing to change the channel on the TV if something about birth comes on. However, there is often also an overlap with some of the milder PTSD symptoms, which often means people with PTSD symptoms may not be identified effectively. For example, feeling anxious or worried or panicky is the symptom of both. Another symptom that overlaps is not looking forward to things or feeling no hope for the future. Difficulty sleeping is also overlapped with both postnatal depression and post-traumatic stress disorder. Inability to see the funny side of things and loss of interest in things or feeling disconnected can often confuse diagnosis. And we could continue with other symptoms that overlap. So you can see that it would be understandable that a GP could misdiagnose someone as having PND if they are only using the Edinburgh scale, whereas if they asked a different set of questions, then it would be more obvious that the trauma was the core issue. Misdiagnosis poses its own issues. The treatment for PND can exacerbate the issue, potentially leading to re-traumatizing the person, in particular talk therapies, as they invite the person to talk through their experiences over and over again, forcing the person to relive it repeatedly. Medication, which may be effective for PND, will not treat trauma. When a person does not recover from their trauma, it can lead them to developing depression, which in turn makes further diagnosis less clear, as the picture is now more complicated. Treatment for PTSD is different, as it involves sensitive debriefing about their feelings, not necessarily about the details of their event. Then we use specific, individualized therapeutic techniques to help them recover fully from their trauma. We know breastfeeding hormones can protect mothers from postnatal depression, or help if it does develop. However, if a mother has experienced trauma, this may affect her breastfeeding journey. For example, either making her more determined to reclaim her confidence in her body, or feeling triggered by the experience, especially if she encounters difficulties.
As Kathleen Kendall-Tackett says about breastfeeding after trauma, for some women it can be a source of further trauma, for others it can be a source of healing. We need to be sensitive with women who have experienced a traumatic birth and who are now having trouble breastfeeding. We need to let them know that they can overcome their birth experience and successfully breastfeed. She goes on to describe what to do if mothers are overwhelmed and recoiling or pulling away from skin to skin due to their trauma. So what is birth trauma resolution therapy? It's a very solution-focused, fast and effective therapy, usually only requiring 2 to 4 sessions, averaging an hour per session. We can treat people with full-blown PTSD or those who have subclinical trauma after their perinatal experience. It involves using a range of therapeutic techniques to eliminate trauma symptoms and to help rebuild the person's sense of self and positivity. The rewind is the key technique. It converts the traumatic memory with those intense emotions and reactions into a normal memory with a story, with a context. The rewind eliminates the worst trauma symptoms so the person no longer has any flashbacks, panic attacks, intrusive thoughts, and they're no longer triggered. Now the mother is able to think about her birth experience objectively and without getting triggered. It's not about sugarcoating what happened, it's about giving it context. Sometimes positive memories surface from their experience that had been eclipsed by the trauma. We personalize other techniques to help rebuild confidence and resilience. For example, we can work on confidence facing into a subsequent birth. This is common as often a mother only realizes the extent of her trauma when pregnant again. We can work on relieving guilt and other negative emotions. Or on improvements in personal relationships, as trauma can sometimes make a person withdraw from those around them. This can be protective of future breastfeeding experiences too. Clients often tell us that they feel more like themselves after just a few sessions, that they are able to engage with their future with hope and confidence. This will also enable them to engage with their baby fully, which is protective for infant mental health and connection, and will help them with their breastfeeding journey.
As an IBCLC, you're potentially one of the first people they can fully express their feelings to during a lactation consultation, due to its supportive and compassionate nature. So there will be enormous benefits to you listening to the mother's story and validating her feelings. Likewise, it's so helpful to use sensitive, supportive language at all times. The clinical details of her stories are only part of the experience, and it would be unhelpful to defend any actions or words of healthcare professionals. Justifying clinical actions without being asked can be invalidating of her experience. How they feel about their experience is the most important thing to remember and to focus on. If they're less than 6 weeks postpartum, it can be really reassuring to let them know that 80% of people are able to resolve their trauma naturally. Reassure them that they will recover, that what they're feeling is a normal reaction to their experience, and that there's support out there to help them to get back on their feet and recover fully. And then providing them with information about birth trauma resolution therapy. Our services include a free initial call and for a short debrief and a screening discussion to help them decide if our services meet their needs. Over our years teaching antenatal classes and other classes, we frequently referred parents to IBCLCs in private practice, and we're hoping for a reciprocal arrangement once you understand how our therapy can help parents recover quickly and effectively from traumatic birth or traumatic experiences in pregnancy and postnatally.
We've been blown away by the results we get with clients. It's very gratifying to be able to help parents resolve the lasting effects of their trauma so that they can get on with their lives, including breastfeeding for as long as they want to. All of our services are WHO code compliant. And if you'd like to know more, you'll find our contact details on our website, mybumpmybirthmybaby.ie, and we'd be happy to talk to you anytime.
Thank you.
Thank you.